Alright, future doctors, welcome back to Vitals and Vices, the podcast where we unpack complex medical topics with a healthy dose of reality, and maybe a little bit of vices along the way. So, I'm your host. I am an MS4 currently, who's been elbowed down in the deep, glorious world of gastroenterology lately. And today we are going to talk about a very common topic, and it's kind of easy, but we need to see different presentations and a similar mechanism of the physiopathology. And today's episode is about inflammatory bowel disease. Specifically, we are dissecting the physiopathology and clinical presentation of Crohn's disease versus ulcerative colitis. Then we will walk through diagnosis, treatment strategies, and we can even hit you with some USMLE style questions to keep you on your toes. So, for starting first with the why. So, imagine that you are on your internal medicine rotation and the attendant asks, "What's the difference between Crohn's and UC?" And obviously, we're going to mumble something like about skip lesions and continuous inflammation, but you want to sound like you really get it, and you have to really get it to understand the difference. And that's what we're going to talk about today specifically. First of all, we have to start with the why to understand the fundamentals. While the exact etiology of both Crohn's and UC remains elusive, they are both characterized by chronic, relapsing inflammation of the gastrointestinal tract, driven by a complex interplay of both genetic predisposition and environmental triggers, as well as an aberrant immune response. But there is a crucial difference, of course, in the physiopathology. Starting with UC, ulcerative colitis, it's more of a superficial striker. For its location, it's primarily a disease of the colon and the rectum, and it almost always starts in the rectum and extends proximally in a continuous fashion. For the depth of the damage, UC is largely confined to the mucosa and submucosa. Think of it as a superficial or a surface level attack. Third point is the microscopic hallmarks that we can find in UC. Obviously, we're going to see crypt abscesses, goblet cell depletion, and even architectural distortion of the crypts. Obviously, because we're having inflammation. Fourth point is the immune profile. Technically, the immune profile is kind of complex, but usually we often associate UC with P-ANCA, which is short for perinuclear anti-neutrophil cytoplasmic antibodies, which are positive in a significant percentage of patients. Next, let's talk about the other side, which is Crohn's disease. Crohn's disease is more of like a deep-seated defender. For its location, it can affect any part of the GI tract from the mouth to the anus. And obviously there's a kicker. In CD or Crohn's disease, we can find skip lesions, or usually it's characterized by skip lesions, meaning we can find healthy tissue that can be interspersed between inflamed areas. Second point in CD is the depth of the damage. CD is transmural inflammation, so it's more of like a very deep inflammatory process, meaning it affects all the layers of the bowel wall. This is a key to understand its complications. The fourth point is the microscopic hallmarks. In Crohn's disease, if we go and we check the tissue under a microscope, we are going to find granulomas, which are a classical sign or a classical mark. We have to understand, though, that granulomas are not universally present. So it's not something that we have to find, or it's like a constant microscopic sign that we will find. We can also see most commonly fissures, deep ulcers as well, and even lymphoid aggregates. Fourth point is the immune profile. In CD, we can usually find, or is mostly associated with, ASCA, which is short for anti-Saccharomyces cerevisiae antibodies positivity. So basically, to summarize everything, UC is a continuous superficial inflammation of the colon and the rectum, while CD is a patchy transmural inflammation that can hit anywhere in the gut. So far, so good. Now, passing to the clinical presentation. So, we have to bring this, we have to know how do these pathophysiological differences manifest in our patients, because it's really important to have that kind of deep understanding. Let's start with UC, or ulcerative colitis. It's more of like a bloody business. So the cardinal symptom in UC is usually bloody diarrhea, and often with an urgency and kind of a tenesmus, which is the feeling of incomplete evacuation. And usually the amount of blood is correlated with this disease severity. Obviously, the more inflammation you have, the more submucosa is ruptured, the more blood you have. So we have a certain correlation between the two. Second thing, we can also find other symptoms that cannot be really specific, like abdominal pain. Usually it's a cramping type of abdominal pain. We can have weight loss, which is less common. It's really uncommon to see weight loss in UC, basically because it doesn't affect any part of the GI tract that is responsible for the absorption of nutriments. We can also have fatigue and even fever. A third point is we can have extraintestinal manifestation. So UC can come with primarily, we should think, sclerosing cholangitis, which is a really common one. We can have also erythema nodosum, as well as pyoderma gangrenosum, and also uveitis and other signs that can be common as well. So to have a kind of a presentation, we can have a case. Let's talk about Mr. Henderson. He's a 45-year-old accountant who you met on your rounds, presumably. So he presented with daily episodes of bloody diarrhea, sometimes up to 8, even 10 times a day. For the past 3 weeks, he lost 5 pounds, and he feels constantly fatigued and describes painful and urgent bowel movements that wake him up at night. So you're going to do your exam, and on your examination, he looks a bit pale, and you note some mild tenderness in his lower abdomen. His colonoscopy later showed continuous inflammation extending from the rectum up to the splenic flexures with a friable edematous mucosa. And what you're going to do is you're going to order some biopsies, and the biopsies are going to confirm the diagnosis, and by visualizing crypt abscesses, which is a classical sign for UC. Now, passing to the clinical presentation of Crohn's disease. So, the classical symptoms of CD or Crohn's disease, basically it's a chameleon symptoms that depend on the affected area. So, if it's the small bowel, you might see abdominal pain, which is usually located in the right lower quadrant, which can mimic appendicitis, and we have to be really careful. Second, you can have, of course, a bad absorption, and significant weight loss. So it's gonna manifest in a significant weight loss due to the nutrient deficiencies. Of course, this type of clinical presentation is mostly related to the location, if the location is in the small bowel. If it's the colon, you'll see diarrhea, and it can also be bloody, but less common and less severe than UC. So it's less bloody than diarrhea in UC. And you can have also abdominal pain as well. For other symptoms, obviously, we can have nausea, vomiting, fever, fatigue, and can even present with perianal disease like fistulas, abscesses, and skin tags. A huge red flag for Crohn's. So we have to be really careful, and we have to do a full examination of the patient. For the extraintestinal manifestation for Crohn's disease, they are kind of similar to UC, but with a few differences. For example, we have erythema nodosum, pyoderma gangrenosum, uveitis, and much common signs as well. But unlike UC, primary sclerosing cholangitis is less frequently associated with Crohn's disease. We can have as well kidney stones and gallstones, which are also seen more frequently in Crohn's disease because of the fat that is not well absorbed. So technically, it's going to give stones and kidney stones and gallstones. So we've talked earlier that Crohn's disease can have more of the complications. We can have more of like a presentation in its complications because it's more of like a transmural inflammation. So for its complications, it can be CD is prone to complications. It can be strictures like leading to bowel obstruction. It can be fistulas, which means we're having an abnormal connection between organs or between two organs or between an organ and the skin. And we can have as a complication as well abscesses. So we can have an example of a case to understand deeply its presentation. So consider Mrs. Davis, who is a 20-year-old student. She's been having intermittent, crampy abdominal pain for months, mostly around her belly button, sometimes radiating to her back. She has lost 10 pounds without trying, has episodes of watery diarrhea, and recently developed a painful lump near her anus that turned out to be a perianal abscess. So we're going to do endoscopy, and her endoscopy and colonoscopy showed patchy inflammation with deep ulcers in her terminal ileum and scattered lesions in the ascending colon, with some areas of healthy looking mucosa in between. We're going to do the biopsies, of course, and they're going to reveal, biopsies revealed non-caseating granulomas. So if we have non-caseating granulomas with that type of clinical presentation, this picture screams Crohn's disease. So to have a clinical presentation is something, and to put your diagnosis for sure is a whole other thing. And if we have a suspicion, we have to confirm it by multiple approaches. First of all, starting with the clinical suspicion that we have been already discussing, based on symptoms, family history, because the bowel disease runs in families, so we have to have like a family history well checked and a full physical exam, and that will definitely lead and orient better to the diagnosis. Second, it's the lab tests. We have multiple tests that we can do, starting with inflammatory marks like elevated ESR and CRP, which are very common. Second, we have anemia due to the chronic blood loss, especially in UC, in ulcerative colitis, because we said that bloody diarrhea is much more common in UC than Crohn's disease. Third, we have albumin, which is low in severe disease or in case of malabsorption. Second or fourth, I guess in the fourth point? Yes, it's the fourth point. Stool studies to rule our infection cause of diarrhea. Like we can have like bacterial infections, so we have to check that as well. We can also check fecal calprotectin or lactoferrin, which are non-invasive markers for intestinal inflammation, and their elevation, or in case we have elevated levels, it can suggest an IBD activity. Last, we have serological marks. As we discussed before, they are not common or less common in urgencies, because basically they can be helpful in orienting the diagnosis and not fully in having or confirming your diagnosis. So you should just remember that the ASCA is for Crohn's and P-ANCA is for UC. Now, coming to the third point for us to fully have a confirmed diagnosis. So the third point is we have to do an endoscopy or colonoscopy with biopsies. So this is a gold standard of our diagnosis. For UC, if we do a colonoscopy, we're going to find continuous inflammation from the rectum proximally with friable edematous mucosa and loss of vascular pattern, and sometimes obviously the biopsies are going to show crypt abscesses. For Crohn's disease, we're going to have patchy inflammation with skip lesions. After ulcers, we can have linear ulcers, we can have strictures or fistulas, and the biopsies are going to show may show, as we said, that it's not really universally found, but it's more likely it's going to show a non-caseating granulomas. Well, it's not always, but you can mostly find non-caseating granulomas in Crohn's disease. Fourth, we can do more imaging like CT enterography or MRI enterography, which is excellent for visualizing the small bowel in case of you want to detect fistulas and extraluminal disease in Crohn's. Second, barium studies, less common now, but you can use it to see in case you have a string sign in CD narrowing the terminal ileum. Third, the capsule endoscopy, which is used to visualize the small bowel in CD, and in case you have strictures or you suspect them, you have to avoid it. Now, coming to the treatment strategies, we have to manage a whole marathon because there are a lot of things to discuss in the treatment. So treating IBD is a marathon, and the goals are to induce and maintain remission and to improve the quality of life of your patient and prevent mostly complications, especially if we're talking about Crohn's. The treatment is highly individualized and depends on disease severity, location, and patient factors, of course. Starting with the general principles. First of all, the lifestyle modification. Obviously, the patient have to go through a diet, avoiding all trigger foods, often low FODMAP for symptom control, but not a cure, obviously. Also, we have to have a stress management and smoking cessation, especially crucial in Crohn's. Smoking is really bad in Crohn's, it worsens the disease, which is and it can be controversial to say this, but smoking can be a protective factor in ulcerative colitis. That's kind of controversial, but I just had to drop this. So smoking, no smoking in Crohn's disease especially. Second general principle is nutritional support, especially important in CD Crohn's, because as we said, we have like a malabsorption and we have to have like an enteral nutrition, especially in acute flares, to avoid worsening the general state of our patient. Now, the second approach, which is the stepped approach, meaning we are getting into medications. The first medication you're going to use is aminosalicylates, like mesalamine or any type of medication. Those are used as anti-inflammatory and topical effect on the gut lining. We use them especially and primarily for mild and moderate UC. And sometimes we can use them for mild colonic when it's a Crohn's disease located in the colon and it's mild. We can use aminosalicylates. However, it's less effective for small bowel CD. Second medication is the corticosteroids like prednisone. Obviously, they are potent anti-inflammatory, very known ones, and they can be also immunosuppressive. We use them usually for induced remission in moderate to severe flares of both UC and CD. For both diseases, we can use corticosteroids. And obviously, we're not going to use them for the long term. They are not used for a long-term maintenance because of their significant side effects. Budesonide is less systemic option for ileocecal CD. We have to know that. Third medication is immunomodulators like methotrexate. So these ones are supposed to suppress the immune system over a longer period, because the objective is to reduce the inflammation, reduce that kind of reaction, so we can have like a less of a complication and less of this disease developing. So for these immunomodulators, they are used to maintain remission and to reduce corticosteroids dependencies. As we said earlier, we cannot use corticosteroids for a long run, and they have slower onset of action. We can use them for weeks or months. Fourth, we have biologics, stuff like anti-TNF alpha agents. For example, we have infliximab or adalimumab. We have as well anti-integrin agents like vedolizumab and multiple ones as well. They target specific inflammatory pathways, and we usually use them for moderate to severe UC and CD, especially if unresponsive and conventional therapies are put. Fifth one already. We have small molecule inhibitors. Technically, these are newer agents currently approved to improve moderate to severe UC, like tofacitinib, and increasingly for CD as well. Surgical intervention. Now, coming to surgical intervention, for UC we can have for ulcerative colitis. Obviously, it's very well located and localized and limited, so we can go or proceed with curative colectomy, which is an option for refractory disease, severe complications, or dysplasia or cancer. We can do that. Second one, which is Crohn's disease, surgery is often necessary for complications like strictures, fistulas, or abscesses, but it's not curative as the disease can reoccur anywhere else in the GI tract. We have strictureplasty, which is an option to wind in strictures without resecting bowel. So to shorten this, if you have UC, ulcerative colitis, you can do curative colectomy. If your patient have refractory disease or severe complications or dysplasia or cancer. However, for Crohn's disease, surgery is not really curative, and you can just do it to in case you have complications. You can go with stricturoplasty in case you want to widen strictures without resecting the bowel. Now, coming to the questions, finally, we can go with some USMLE site questions to test your knowledge, giving you some kind of cases, and you can guess the diagnosis and answer the questions. So let's see if you're paying attention. Here are some couple questions. So starting with the first one, you have a 32-year-old man presents with a 6-month history of intermittent cramping abdominal pain, primarily in the right lower quadrant, associated with 2 to 3 episodes of non-bloody diarrhea daily. So he has lost 15 pounds despite a good appetite. In your physical examination, you're going to find a mild tenderness in the right lower quadrant and a pre-anal skin tag. Colonoscopy shows discontinuous inflammation with deep ulcerations in the terminal ileum and ascending colon, interspersed with normal appearing mucosa. And you're going to do your biopsies, of course, which are going to reveal non-caseating granulomas. Which of the following most likely to be a diagnosis? Ulcerative colitis, irritable bowel syndrome, or celiac disease, Crohn's disease, or diverticulitis? Obviously, you're going to pause to think, but at this point, you know it's Crohn's disease. The key feature here, or the key features here, are the right lower quadrant pain, significant weight loss, non-bloody diarrhea, pre-anal disease, discontinuous inflammation, so skip lesions. We're talking as well deep ulcerations and especially the non-caseating granulomas on biopsies, which, as we said, are not always found, but in this case are found. These are all hallmarks of Crohn's. So you see, typically, if we're talking about ulcerative colitis, it typically presents with bloody diarrhea and continuous colonic inflammation. The IBS has no inflammatory markers or structural changes. For the celiac disease, it presents with malabsorption, but typically without the specific inflammatory or perianal findings. Diverticulitis is usually an acute inflammation in older patients. So our patient is not really old, so you can just orient yourself with that type of information. Second case, we have a 55-year-old woman with a 10-year history of ulcerative colitis. Presents with a 3-month history of worsening abdominal pain, distension, and decreased stool output. She has also noted progressive jaundice and pruritus. Lab studies show elevated alkaline phosphatase, gamma-glutamyl transferase, and direct bilirubin. Which of the following extraintestinal manifestations is most likely contributing to her current presentation? We have the first one, erythema nodosum, pyoderma. Second one is pyoderma gangrenosum. Third one is primary sclerosing cholangitis. Fourth one is uveitis, and the last one is sacroiliitis. So the answer is, obviously, you can pause if you want to think, it's primary sclerosing cholangitis, PSC, which is strongly associated with UC, ulcerative colitis, as we already explained, particularly in patients with extensive colonic disease. So the symptom of abdominal pain, distension, jaundice, pruritus, and elevated cholinistic liver enzymes are classic for PSC. And the other options are also extraintestinal manifestation of the intestinal bowel disease. But they do not explain the liver-specific symptoms and lab findings described. So there you have it, a deep dive into the vitals and vices of Crohn's disease and UC. Always remember the key distinctions of both of the diseases. First, UC is superficial and continuous. It's usually in the colon and the rectum, and typically presenting with bloody diarrhea. However, Crohn's disease is transmural and patchy, and it can affect any part of the GI tract and often presents with pain, weight loss, and complications like strictures, fistulas, etc. The diagnosis relies on a combination of clinical pictures, lab, and crucially the gold standard, which is colonoscopy and endoscopy with biopsies. And treatment is a lifelong journey utilizing a stepped approach from 5 ASAs, we talked already about them, amino salicylates, to biologics with surgery as well as an option for complication or refractory disease. You are now armed with a solid understanding to tackle those IBD patients on the wards and ace those USMLE questions. Keep studying, keep learning, and remember, even when the gut feels like it's grudge match, you are the one who can help meditate. Thank you so much for listening. Find me in the next episode.